So this next group of videos include what's called the atypical antipsychotics or the second generation antipsychotic drugs. And from a mechanistic standpoint, these are second generation because they're new and improved drugs on the first generation, which were also called the typical antipsychotics. Mechanistically, these drugs have a higher preference of serotonin compared to dopamine antagonism, and they're all listed right here. How are you going to remember the difference between these two? We're not going to talk about the typical antipsychotics in this lecture. We're going to reserve those for the next case or the week after. But the typical antipsychotics preferentially target dopamine, and the way we can remember that is looking at Homer Simpson saying dope. And of course, the second generation atypical antipsychotics target serotonin, and so S for second, S for serotonin, SS Superman, and so that's just how I remember it. Several conditions can be utilized or can be treated with antipsychotics. Bipolar disorder, of course, severe depression with comorbid anxiety, OCD, Tourette syndrome, and then a lot of these antipsychotics have been used off-label for sedative effects, insomnia, as well as agitation. And a really cool factoid, the first clinical study looking at efficacy of some of these antipsychotics was responsible for producing the first double-blind clinical trial. And so that's basically where, the patients nor the physicians knew which treatment group they were in. The atypicals, as I said before, have a preferential blockade of serotonin, more so than the dopamine receptor, and so that translates to less CNS effects, but more metabolic type effects. And so those side effects look like metabolic effects, weight gain, diabetes, hyperlipidemia. And so from a clinical standpoint, these drugs are indicated for bipolar disorder as well as schizophrenia. For the schizophrenic patients, these drugs are good for both positive and negative symptoms, which you'll learn about. And they're also second-line therapy for OCD, with SSRIs being the first. As I said before, a lot of these CNS drugs have several affinities to different receptors, and then that kind of explains a lot of the side effects that you're going to see. And so, for example, the side effect of orthostatic hypotension, including tachycardia, is often the result of mixed activity in terms of alpha-1 antagonism. Clozapine and olanzapine have some muscarinic receptor antagonism, and that we think produces a hyperlipidemia. Almost all the drugs in this category have some varying degree of histamine subtype 1 receptor antagonism responsible for producing sedation. Some of these drugs have the ability to produce QT prolongation, and some of these drugs are also associated with a high degree of excitatory postsynaptic movement disorders. And there's also some underlying ketoacidosis and diabetes susceptibility production with these drugs as well. I want to talk about a few selected drugs, basically because they've been called out in the case, and some of our patients who we're going to be talking about in the live session activities are going to be on some of these drugs. And so the first one we'll talk about is the brand name Abilify, and this is the Aripiprazole. I can never say that one, but it came out okay. And this was advertised as an add-on therapy for depression, but in 2007 it actually got FDA approval for that. This is an oral quinolinone. This is really the first atypical antipsychotic used for bipolar adjunct therapy. And that's due to the fact that it has partial agonism of D2 and D3 receptors, as well as serotonin receptors, and it's an antagonist at a subtype of serotonin receptors. And I'll explain that dichotomy later. There's some H1 and alpha-1 affinity as well. And so basically some preclinical research demonstrated that the atypical antipsychotics can reverse the suppression of firing of the norepinephrine neurons produced by selective serotonin reuptake inhibitors through the antagonism of 5H2 subtype A receptors. And so you can see Abilify added to SSRI treated patients as an adjuvant therapy. Clozapine is really the best drug for the problematic negative symptoms seen in schizophrenic patients. You'll learn about all of these schizophrenic side effects and effects in an upcoming case. There are some movement components to that because of its dopamine activity, and we'll spend some time talking about that as well. But the side effects, I really wanted to focus on the side effects of clozapine, is that even though it's small, 1% of the population may experience agranulocytosis, and so for this reason you must monitor neutrophils. Cardiomyopathies are also common with clozapine, as well as a lowered seizure threshold, so patients with a history of seizures or epilepsy would probably best be not on this drug. And there is a paradoxical wet pillow phenomenon. These patients drool like a St. Bernard, so there's some muscarinic effect. We're not really quite sure. It seems to be a muscarinic antagonism, but that doesn't really explain the drooling, and so it's somewhat paradoxical as to why this occurs, but it does occur in lots of patients. So clozapine was really important because it really kind of revolutionized the second generation of the atypical antipsychotics. It brought about olanzapine, which is very similar to clozapine. It's not as efficacious, it's not as potent, but it doesn't really produce agranulocytosis. Risperidone does see some dose-dependent movement disorders, and then quetiapine, which is basically a dopamine serotonin antagonist, has been really, really useful. This drug has mixed activity. All of the molecular targets are listed here. It's both an antagonist at most of the receptors that are important, but a partial agonist at a serotonin receptor subtype. And what's important here is that the partial agonism actually produces an inhibition. And so this is one of those feedback relays where stimulation or agonism of a receptor produces an inhibition of serotonergic neurons. And then, of course, the postsynaptic receptors of this subtype are expressed in various tissues within the CNS. The indications for this drug are numerous, which is why I included it. It's also included in the case as we go through the case for this patient. What was her name? Sarah O'Neill. You'll see this drug and the usefulness of this drug. So lots of indications: bipolar disorder, schizophrenia, mood disorders, major depressive episodes with bipolar, and then patients who responded poorly to the kind of the first frontline therapies all seem to do well on quetiapine. And it really probably comes from all of these targets being inhibited. So H1 is probably more sedating, alpha 1 as well, but D2 and 5-HT2A are really probably the kind of the main driving points to this drug being used for all of these disorders. Okay, so I think that'll end the second generation or the atypical antipsychotics. We'll come back to them probably at least once, if not twice more. So that is not the end of them. That was more or less just kind of a brief introduction to them.